is RX Insights. This is, interactive. There's no real agenda. We're collectively learning here. So I encourage everybody to turn your cameras on if you're comfortable. The meeting is recorded. It's going to be on peer-to-peer.academy. And so if you do want to go back, if any nuggets or pearls come out of this, feel free to look it over. Tonight we're going to just do cases. So I think Ken, I think you got a case. Ron, you got a case. Jess, you see a case too?
Yeah.
We're just gonna start with that, and we've done this before. We've gotten through like 1 or 2 cases a night, and just kind of spawns discussion, which is great. And like I said before, we're all collectively learning here. So speak up, and if something you don't agree with or something that you would have done differently, I think that's valuable. We're all here to learn. So Jess, you want to lead it off? You want to share your screen, and do you have anything to show?
Yes. So let me pull up my case here. Can you guys see my screen?
Mm-hmm.
Okay. Okay. So this is a pretty straightforward case, but there was some not so straightforward things that happened throughout the case that I thought would be kind of good to go over. And feel free for anyone to chime in throughout this case if you have input or something maybe you would have done differently, or have feedback on how you have done it before. But this is an LAL plus case. So I don't know about you guys, but a huge fan of LAL plus compared to just LAL with the visual acuity and the outcomes. So this case is just going to show you how awesome this patient's visual acuity was at the end. But basically, I saw this patient for their cataract consultation. It's a 56-year-old African-American female. She was complaining of constant blurry vision, halos, glare, and just wanted her vision to be what it was like after monovision with PRK. So she was had monovision with PRK with her right eye for distance, left for near, and was complaining because she was having to use her readers more than she ever was before. As you can see, her entering acuities uncorrected were already pretty good. She was 20/20 -3, J2 -2 in her distance eye, and 20/50 -1. Penhold at 20/20 -3, J2 -2 in her near eye. And that's her AR. She didn't have glasses because she was just wearing readers over the counter. So spherical equivalent of like Plano in her right eye and -2 in her left eye. So this patient from the beginning was screaming to me light adjustable lens because she's post-refractive, has really high expectations, and already in her distance eye, one eye, she's seeing 20/20 -3, J2 -2 because she's young, she's 56. She also had a pretty regular topography for being post-refractive. She was myopic PRK and had kind of a little bit of an inferior steepening on her topography. So she almost had this like multifocal cornea effect too, which gave her an extra boost up close as well. Mostly NS cataracts, but she did have some PSC and cortical as well. So that's why she glared down to 2100.
Leo, no. No, Leo, no. Mama's working, Leo. I can't move.
So visit 1, the patient came in for the first treatment and wanted monovision setup. She was happy with her distance vision, but felt like was still relying on her bifocal for near vision. So you can see with this coming in with entering VAs, she already had such a strong entering acuity. And these are those cases that sometimes you see and you're just like, oh no, my surgeon hit it out of the park. I hope I don't mess this case up.
I hate that. I always get mad at my surgeon when he does that. Hey man, you got to leave me something to do.
Right? Because the right eye was spot on Plano with the manifest, 2015 -2, J2. And then the left eye was -1/4, 20/20 +2, J1, with even some letters on J1 plus. But this patient, even though OU could see J1 plus -1, they said it wasn't easy at all. She had to strain. So yeah, this is kind of an interesting case because I know we've mentioned this before of like a neutral treatment. So that's what I did for her right eye was a neutral treatment where I targeted Plano with the Manifesto Plano. And then the left eye was a little tricky. Since she had such a regular cornea, even though it was post-refractive, it wasn't very aberrated. It looked pretty regular otherwise. I did activate the negative SA, and so that's why I targeted a -1. I went a little bit more than -0.75. just because typically my monovision with LAL plus, I'll do like minus 1.25 to minus 1.5 for the near eye. However, with this patient, since she was already seeing well at near, I felt like I didn't have to target as much. So went for, in -1, looking for minus 75 to -1 endpoint, and started the patient on some artificial tears 4 times a day. And then patient came back visit 2. She said her near vision had improved, as you see J1 plus for the OU vision, but she felt like her vision wasn't as crisp at any range. Her eyes felt dry. In the right eye, she went from J2 to J3 -1, and I thought that was interesting. That kind of drew in my attention because I did a neutral treatment, so I didn't expect anything to change. So sometimes when I see that, I'm thinking, uh-oh, dry eye, and she said too, her eyes felt dry. So looked her under the slit lamp. She had some very mild SBK, and then very mild PCO noted as well, both in right eye and left eye. And I did note some trace PCO in her right eye at the first visit as well, but it almost looked a little worse at this second visit. But before I did anything with the capsule, I decided let's postpone due to dryness, increase your tears every 2 hours. Let's follow up in another week. So patient came back for visit 3, said that her vision was better after the dry eye treatment in her left eye, but her right eye still felt like it wasn't clear at any range. And again, I'm seeing a decline in her vision, 20/20 -1, J5 +2, and I hadn't done anything to that eye other than a neutral treatment. So I went ahead and looked at her capsule a little bit more closely, and I did see the PCO was in her visual axis, even though it was mild. So I went ahead and did a glare on her, and she glared down to 20/50. And I said, let's go ahead and postpone again. Let's do a YAG today since you're here in the office already. So we dilated, and the surgeon went ahead and did a YAG on her. And she came back visit 4 with vision improved to all ranges, using readers just for extended reading and dim lighting in some instances when her eyes are dry, but overall doing really well. And you can see in that red eye, she went back to 2015 J2, which is what she came in with her entering VAs. Again, still refracting at Plano. The left eye, even though I had targeted -1, she ended up a little more myopic at -1.25, but she liked where she was at. She was 2015 J1 plus OU. Still very mild PCO on the left eye, but since she was 2015, not complaining of anything, we'll just monitor that. Started the lock-in process, and then visit 5, finished the lock-in process. So I thought this was kind of interesting too, just between lock-in 1 and lock-in 2, just another thing to kind of point out. Sometimes you'll see a little decrease in vision between lock-ins, and sometimes there is a little shift in the prescription. From a lot of my experience, what I've seen is it's a lot just related to dry eye again. So I wanted to just bring that up because something to just really make sure to educate patients on prior to the lock-in. I'll typically tell the patient, this is a brighter light. Because of that increase in brightness, you will likely experience an increase in dryness, which can cause a decrease in vision. Don't be alarmed. Once your dry eye stabilizes, vision should go back to what it was today. Just hearing that, patients feel a lot more comfortable. I also tell them too, it's gonna feel uncomfortable. It might feel like a sunburn feeling, or irritated, or painful, or watery, even into the next morning. Because these are the patients that will call you at 8:30 p.m. at night. I don't know if any of you guys have experienced when you're on call, and saying, my eye still is so dry and irritated, and you don't want to be the one that didn't educate them on that. So I thought that I would just mention that as well, as just something I've really learned with my experiences, really educate patients, even prior to starting the lock-in process. So
Jessica, what's your protocol? So like I definitely do that, and I think that's a fantastic idea. And if they're expecting it, it's not a complication. If it's something that's unexpected, it's a complication and something went wrong. So what I do, I tell them to keep using their teardrops. We have them on a regimen 4 times a day with a preservative-free drop, and I tell them to use it at least 2 more weeks past the lock. And what do you tell them about that? Do you have them keep using that? Do you put them on a low-dose steroid at all? Anything like that?
yeah, I'll typically have them increase the tears, depending on how dry their baseline is. But typically I'll tell patients increase their tears for every 2 hours for a week. And then So after the first and second lock-in, they'll do for a week. So in between lock-ins and then for a week after the final lock-in. And then I have them go down to 4 times a day for another 6 to 8 weeks. So I tell them dry eye typically stays flared up for about a month or 2 after the final lock-in. And that might be a little aggressive. I'm sure they, a lot of them come back at that 6 to 8 week final post-op check and they're like, I'm not doing tears 4 times a day, but my hope is that then maybe they'll get twice a day or so, and I won't have to worry about having to treat dry eye again when they return for that final post-op check.
Have you ever pulsed them on a light steroid, just temporarily for a short week or 2?
Yes, yeah, I do like doing like soft steroid, like a Lotamax, or something. We get a lot of samples in our office, so sometimes just send them home with a sample, and it's enough, like the little Lotamax SM sample, just to use for like, it'll last them about 5 days. I tell them to store it upside down inside the box so it lasts a little bit longer, and that'll help too. So if they're already on tears, if I had already increased every 2 hours, my next line is like a little Lotamax, or just any steroid pulse as well to help with that. We're still working on a good dry eye protocol at our practice. We're trying to come up with something that's better, but this is what we found has worked pretty good for most patients. The post-refractive patients are the toughest often though, so I will educate those patients at their first adjustment that you've already had a surgery, and then now you've had cataract surgery, and now you're having these adjustments. You're someone whose dry eye's gonna likely flare up more. So I'll just be like, make sure you're using these tears throughout the adjustment process. I can't stress it enough with you. And you're someone that we may have to postpone during the adjustment process just because of your eye, surgery history. So I don't know, what's your guys' experience with dry eye treatment? What has worked well for you guys in your practices?
I'll say for me, I'm a big fan of, I'll treat it pretty aggressively. And what I mean by that is I'll do Isuvus with Vivi. I like that combination, and it seems to work well. We usually get pretty good samples for Vivi. Isuvus, I might have to prescribe, but that's usually just to get them through the first couple of days, the Isuvus, and then the Vivi will kick in after that. So.
I think that's a good way to do it. I've had success with it. Go ahead, Ken.
We do something similar. I'll definitely use this. I don't hesitate to use a steroid. We do use a lot of Vivi because it has a nice combination in it. I've gotten a lot more aggressive during the process, and I'll coach patients quite a bit right through the lock-in saying, we're going to actually rev up your dry eye just because we're messing with these eyes with doing these treatments and doing this stuff. You've already had a surgery even, and now we're doing these adjustments, and so we're actually irritating the surface a little bit, so we're going to be more aggressive. And another one I'll use when I can get it for the patients is Mibo, because we have a lot of evaporative problems down here where I am in Texas. I'll have T-butts of 3 seconds and the patients are complaining about unstable vision, and I'm like, that's because you can't stay in focus. And I can put them on something like that, and that will actually stabilize them so we can actually do the treatments. And I'll have them do that. They'll say, do I have to stay on this forever? And I'll tell them probably about a month after your final lock-in, then we can get off of that stuff and see how you do, because we've stopped messing with your eyes and your ocular surface can go back to normal. And that came out of my personal experience because I'm not particularly dry, but after my surgery, my dryness kicked in at about week 2 and continued definitely through week 8 and through my lock-in. After I locked in and I wasn't messing with my eyes anymore, I finally got back to where I was pre-surgery. So as long as I was messing with my eyes, I felt that my dryness kicked up myself. So I translated that and ramped up treating my patients afterwards.
I had someone with filaments after one of the treatments, and the best treatment I found was with a bandage contact lens that we had them wear for about 5 days. Final lock-in, everything was great, but it was a little scary. But
That's no fun.
Yeah, the bandage worked. In fact, after her last lock-in, she felt okay. We put the bandage on it for the weekend anyway, took it off on Monday, and everything was good. Is anyone else using bandage contacts afterwards? when needed to?
I've done an amniotic under a bandage once or twice. And it was a patient who had ABMD. I mean, it was not an ideal case to begin with. Or she had a recurrent corneal erosion. I think that's what it was. And so after, she popped another erosion after the final lock-in and came back in pain, the normal thing. And so I put an amniotic on it just to do everything I possibly could. Things got better. But I know that I had a part in that recurring, and the amniotic help. So Ken, you brought up MIBO. I love MIBO, not necessarily specifically for the extreme dry patient, but I have found the most success using it for the 2015 unhappy patient. You all know those types, the ones who are, especially they're post-refractive, their cornea is a little bit irregular to begin with, their topography is not perfect. And they're 2015, but they're complaining of higher order aberration type complaints. Almost always MIBO helps. I've found that to be, the perfect niche for that. And I use it often in other parts of my practice too, but especially for those patients, that's my go-to, where you've got those complaints, fluctuating vision, all that stuff. MIBO works great in my experience.
I have a question for everybody. I love MIBO as well, but I get so much pushback from insurances. So I've been using BlinkRx more, and I think that's been a little bit more successful. Do you guys have any tricks for kind of working with insurance and prescribing MIBO?
So for commercial patients, it's $0 for the first bottle. And then if it is covered under their insurance and they don't have Medicare, it'll be $30 or less. If they have Medicare and it gets approved, it's usually like $250 or more. So I usually don't even prescribe it for Medicare patients, unfortunately. But if it gets denied by any insurance coverage, then they can get it for a cash price of $60 through BlinkRx. And I usually don't do the appeal because I'll just be like, they'll get it for $60, and that's typically affordable.
I have a question.
Okay, thanks.
I know I have a referring doctor, and he recommended for Medicare patients not to use their insurance, and so they get it cash price for $60. Have you guys tried that?
Nice.
Done it yet? I didn't know if that was copacetic or not, but thoughts on that?
Can you do that? I don't know. I plead naivety here. Or is
And
that
then
not
there's the Evo tiers that are available in Europe, which I'm not sure if we should be condoning purchasing something that's not FDA approved and available in the US, but it's perfluorohexyloctane as Evo tiers in Europe that they can get for about 40 euros, including shipping. So that's an alternative.
Interesting. I mean, if it is cheap and affordable, especially for commercial pays, a lot of our LAL patients are younger. I mean, they're going to be more likely. I mean, a lot of them are Medicare still, but out of our cataract volume, most of them will be more under. We can get it for cheap, and it's only going to be a temporary thing. Typically, I'll have them use it for the bottle length, a month. But yeah, I don't know about that, Ron. I don't know if we can. I honestly don't know.
Yeah, I
I don't know
wasn't
if
sure.
about that system.
I think I had one, maybe two folks that they just didn't use their insurance, and they were able to get it for like the 60.
Nice.
I have to plead a little bit of ignorance. I do have somebody in our office that helps me with that. So I know she was the one that the rep talked to about it. So because we use BlinkRx and PL Pharmacy, which is down here as well, and they do a pretty good job of offering alternatives to the patient. So
I have a question if anyone has noticed any correlation between EBMD and kind of map patterns after the light treatments. If the
Actually,
light treatment induces this.
I've had a patient that I'm working with currently, and it's been a nightmare, to be quite honest. And it's weird because I usually did not have any issues in terms of recognizing it. But then after the light treatments, I'm like, and she's been having significant fluctuations in vision and just overall unhappy with the vision. I noticed her ABMD is just more prominent. And I don't know if it's just because I was looking for it more, but I'm curious what other people are thinking as well.
Yeah, I've had a few who I've noticed have it after the light treatments, but maybe I just, I don't fluorescein stain everybody prior to surgery, which now I'm thinking maybe I should, just to, catch that.
Yeah, I do stain everybody before surgery, because I am looking for it because it can be troublesome. But we know, generally speaking, I think that cataract surgery in general, I can see a little hiccup in ABMD with any of my lens patients, with any of my cataract patients. And if they have it anywhere near the visual axis, I think twice about some of these lenses, or we talk about taking care of that beforehand. But something you could try, I've tried a few times, you can try like a amniotic membrane to see if that'll smooth it out. If you're having a nightmare with a patient that, they already have the lens in, you're already partway down the road. I've done that a little bit and it did help with getting that to smooth out to clear up their vision a little bit.
I have a patient too who had some very mild ABMD, but it was central, and during the treatments it affected vision a lot more than I thought. So I did have the patient go back to the surgeon and get a superficial keratectomy mid-adjustments, and I ended up pushing her out a month. So I got a topography prior to the SK and then a month later. And then I followed up again like 2 weeks after that just to make sure it was stable. And she was good at that like 6-week mark. We started back up on adjustments and she's doing well now.
Yeah, I have several patients. We're fortunate to have the eye trace, which will give us reading on corneal aberrations. And I think has saved me quite a bit in doing Super K with Procara and then postponing by about 6 weeks. But even your topographer, if you see some wonky irregular astigmatism and they have EBMD, and I've seen a non-central that can still cause some significant irregularity on their topo. It's a really, you'll save yourself from a nightmare, treating that patient. First do Super K with Procara.
I have a quick
Yeah,
question.
I agree.
Sorry. Quick question along those lines. I have a patient coming up this week actually who had a raindrop inlay and got to me for the adjustment. And I was like, holy cow, you got a raindrop inlay. You got to get that out. So she's had it removed now. Anyone adjusted anybody with significant corneal haze or scarring or any irregularities to the corneal clarity that way, apart from the ABMD we're talking about?
Not
I've
like
actually
that,
had a
but I'm
patient with an
curious.
inlay. Sorry, go ahead.
No, I have not, but I've been curious about, because I have experience with raindrop years ago, and we did a handful of them, and I was always curious about how that would affect things. So I'm actually genuinely curious about how things go for you, Chris.
I had a patient who had an inlay removed. If I remember correctly, for her, she did totally fine. The only thing I did was just avoid inducing the EDOF. And really, I didn't have any issues in terms of refraction or visual acuity or anything like that. But I mean, her cornea may have been different from your patient. She, in general, her cornea looked fine. But I didn't make a whole lot of changes. The only difference was, if I remember correctly, I just made sure I didn't induce the EDOF in that one.
Were you there throughout the removal, or was it removed prior to?
I was not there. So the way that it works in my clinic is I see the patients after their cataract, after the cataract implant. So my corneal specialist, who she also does most of the LEL surgeries, she had done it prior, and then I think I saw her 6 weeks after something. I can't remember off the top of my head.
Okay, thank you, everybody.
Hey, Nick,
Yep.
I've got kind of a question to pose to the group about YAGs. So Jessica, you guys YAG this individual pretty quickly, and you want to talk a little bit about, the timing of the YAG, the protocol, because I know it's different than your conventional YAG. You got some comments about that?
Yeah, so I'm finding more and more often we're doing YAGs mid-adjustments just because I'm finding a very mild amount of PCO can make a huge difference because their optics through these implants are just amazing. So what we do is I'll confirm with a glare bat. So I do make sure they still glare bat down. if it's really mild, not super obvious, I make sure they glare back down. And then we will do the YAG the same day that they're there for the adjustment, since they're already there. Our surgeons are so great. They will add them on to their already busy surgery schedule, since these light adjustable lens patients are like premium cataract surgery patients. So I'll just let them know we're going to add them onto the surgery schedule. They'll go over, and then we actually no charge these YAGs, because we consider it part of their package
Right.
for the premium lens. And then we follow up with them a week later on their normal adjustment process and go just right back into adjustments. We found only a week is really all you need after the YAG for the refractive stability.
I agree. You could probably go in a couple of days, actually. So
Yeah, typically we do about a week if we do. We originally were, so the lenses are pretty easy to pit. I don't know if anybody's got experience
Yep.
with doing a YAG, or
Yeah.
you know, they're very easy to pit. So you do want to be careful if anybody here is doing it. You know, I don't do them here, but my surgeon, I've seen and learned secondhand through him that don't do a cruciate pattern. You don't want to do a cross. You don't want to go through right through the central optic. You want to do a circle or a horseshoe, and you know, be as gentle as you can, because if you pit it, I mean, these, like you said, Jess, these optics are just so incredible that any irregularity or imperfection is going to be noticeable.
yeah.
Awesome.
And-
One thing I wanted to bring up. So Jess, you talked about inducing the negative spherical aberration, and this was an LAL plus.
Correct. And now that has changed.
Yes.
So
Yeah.
I
Has
thought
any?
you might bring that up too.
Yeah, I think it's important to talk about. Have you guys had the updated software on your systems?
Yes.
Yeah.
We have.
So is everybody aware that the LAL pluses no longer induce the negative spherical aberration automatically?
No, sorry, I wasn't aware. Can we talk about that for a moment?
Yeah. So with the LAL plus, so any LAL plus which would have an 8 as the first digit in the serial number, the normal circumstances that you have to, the normal conditions you have to meet to induce the spherical aberration. So it's got to be the first treatment, negative 50 or more in the myopic direction. Those are the three things. With an LAL plus, you no longer automatically do that. So let's say hypothetically you've got a plano right out of the gate and you're shooting for negative 75. Typically that would induce the negative spherical aberration. If it's an LAL plus, it doesn't. So you don't have to worry about, you know, quote unquote, tricking the system anymore with the LAL plus. Now, if you still want to do that, that's when you have to trick the system. So they've kind of reversed it on us. So you still have to trick the system to make it think that you have a regular LAL if you want to induce further depth of focus for the LAL pluses. It's super confusing.
But Nick, I guess the question would be, if the LAL plus is designed to give you an increased EDO in and of itself, what would be the purpose of inducing a pulse reaction on the part of the lens to further enhance that? I'm not sure I see that value.
There's still advantage to it. And I only do this in virgin corneas and patients who are perfect candidates for it. So naturally, the LAL plus has built in, call it a quarter to a half diopter. And then by doing the added depth of focus, you're getting an extra quarter to a half diopter, you know, ballpark.
Okay.
So you're just increasing depth of focus. So with the LAL pluses, especially if they've got the added depth of focus, I usually only end up at a -1 target typically for most people. So you don't have to go that far. And then you end up with a scenario like Jess had. So Jess, I thought it was really noteworthy that you're -1.25, right? Is what you ended up with. And she was 20/20 -2.
For
something like that for the distance.
Yeah, 20/20 -1, 20/20 -2, something like that. But yeah, J1 plus.
Yeah. So that's what you're preserving, right? So if you have more depth of focus, it works in both directions. You're going to preserve binocularity depth of perception. And so you've got patients, I get that all the time, where they're -1, and with a monofocal, a -1 would be 20/30, 20/25, maybe, but they're 20/20. So you're preserving that. But with the new LAL plus, I think there were enough issues where I think perhaps it was being induced when it shouldn't have, and it's trying to almost, you know, protect the protect the user from doing something they shouldn't be doing or that they're not aware that they're doing, because it is kind of complicated to think about all these steps. So no, with the new update, you no longer would get that. You don't have to worry about that.
So
Try to make it
Jessica,
easier.
I just have a question really regarding your case. Initially, the left eye was practically plano. The patient was seeing J1 and 20/20. So if that was the case, why did you make that patient go up to -1 for her non-dominant eye?
Yeah, I think that's a great question. I think I could have initially just targeted like a -50 and probably been enough, but this case we hadn't updated the software yet, so I did want to activate the EDOF, the extra EDOF in this patient, even though vision was still good at distance. I thought I could get a little extra more near without taking away too much from that distance, because she was J1 +2 on the J1 plus line, 20/20 +2 J1, and then +2 letters on the J1 plus line. So I was hoping for like a -75 to -1 to activate the extra EDOF, and she just ended up more with a -1.25. I was kind of nervous with her too, just because her history of monovision, she was a -2 in that left eye, and she kept saying she wanted more near. So I think she held things a little bit closer than the standard patient. So even though she was seeing J1, even some of the letters in the J1 plus line, that's not where she liked to hold it. She liked to hold it a little bit closer. So I felt like activating a little bit more near that eye, she could hold it a little bit closer to what she's used to. So that's why I ended up going with that. I think you wouldn't be wrong though to have not activated the EDOF, just go for a -0.5, and that might have been enough. But I think it's more of just like where she liked to hold her reading material, her aim with PRK prior to cataract surgery, and just the patient's preferences. That's what's so cool about this technology, is it's just so customized to every patient.
So, so I remember for the last meeting that we were saying something about, I think it was Joe, that where you weren't really actually conducing to spherical aberrations to basically like any of your like LAL plus patients. With the new update, I'm guessing you don't really have to do that anymore, or are you still keeping everything status quo for yourself, Joe?
Well, because I don't have to trick the system anymore. It's kind of like my normal everyday. We weren't inducing the negative essay for most of our patients, and it seemed to be working well through our few offices that we have, and we had less problematic patients with that extra EDOF effect that some of our patients were dealing with, which would lead to possibly a lens exchange, which is our ultimate goal, is not to have to go back and redo a lens. So things have been kind of more simplified for our offices, and we seem to do just fine without adding that extra EDOF effect for people. So
Yeah, I think the advantage is there for the right person, but it's not necessary. And I think that's what RxSight has done with the update. They're trying to make it so there's less, because there was enough. I think there was enough problems that came with it, especially in the LAL plus, and so this simplifies it. And the advantages of the LAL are still crazy. They're awesome. That little extra has more risk associated with it if it's done in the wrong person. So it's simplified now. You
yeah,
can trick the system though to do it if you want to. There is ways to do that.
and I would agree. I mean, healthy virgin eyes, I think the likelihood of it being a problem is greatly reduced. I think if we had the capability of measuring higher order aberrations in our office, then I think it could be utilized more often and in a more effective way. We just don't have that capability.
Yeah, I use our aberrometer for that reason a lot of times. On the
Mhm.
first treatment, we have a Wavedyne that we use, and um, I'm trying to figure out exactly. There's so many numbers that this thing spits out, but if there's a above a certain threshold, I will avoid doing the added depth of focus. If there's below a certain threshold, if they're post refractive, I'm not going to do it. I
Okay.
always avoid it. Or if they've got any sort of irregularity. But even if it's a virgin cornea, I still look at the aberrometer just to see what their natural system has included, and kind of use that to guide me. So use the tools that you've got. You don't have to have an aberrometer. I always encourage doing a pentacam on the first, or a topography on the first treatment to see what's changed. You've got your pre-op topography, but things change after surgery. And so using that as your guide to see if there's a high likelihood of something like coma or trefoil, I mean, you can get an idea of what they're prone to and use that to guide your decision on if you're going to use the depth of focus or not. And sometimes I use that to guide my target too on my near eye. I mean, if they do have a little bit of an irregular cornea, that does work in their favor, and it does provide a little element of multifocality. So avoiding the depth of focus, but maybe still moving in the myopic direction a little bit more is helpful, because that gives them a little more depth of focus just naturally. And again, you're kind of using your topography to guide you for that.
Yeah, that's how this patient was, where she had a little bit of some inferior steepening. So didn't technically probably have to activate as much of a minus target. She probably would have done fine with a little less as well. But I will say my experience with post-refractive corneas, I'm typically the same way. I'm more conservative, but if it's myopic, I do find they still do well, since they're centrally, they don't have as much irregularities like hyperopic LASIK or hyperopic PRK or RK patients. But I do avoid, I just avoid the LAL plus implant in general for RK patients and hyperopic LASIK. We just do LAL instead of LAL plus, and then I won't typically activate, or I won't activate the negative SA in those patients.
Yeah, I think I said that backward. I want to backtrack. If they've got an irregular cornea, I don't go as far in the myopic direction. So like the RK eyes, we've all had RK eyes. You don't really have to go that far for those, because they've got that depth of focus. Rarely you may be inducing any sort of myopic treatment on those, because they've got that. But yeah, hyperopic LASIK is different than myopic. Hyperopic LASIK, you're going to induce a lot of negative SA naturally. And then to combine that with the already provided negative SA in the lens itself, possibly combining that with further inducing depth of focus with more negative SA, kind of asking for a problem. So yeah, I don't do it in those cases. Any more questions on that case? Or do you want to go to the next one? Ken, do you have your case, or Ron?
I do have one.
Bring it up.
It's pretty simple. See if I can make this happen. Give me 1 second. All right, you guys got that?
No. There you go.
Yes.
Okay. This is actually, it's not as fancy as Jessica's. Okay, I kind of put this together last night. Speaking of RK, this is a patient that I'm not particularly proud of the timeline on this, but I wanted to share because we ultimately got to a great place. But we had to do a lot of talking and trying to figure things out for her. But this isn't a big long presentation here. So I had a 69-year-old. I don't know where that 40 came from. Sorry, but she was a post RK patient with 8 cuts on the with about an 8-cut RK with AK. She had worn monovision with the right eye for near. I had seen this patient for years as glaucoma suspect, pretty low risk, not too bad. And she had a history of some lattice and whatnot. Finally got to the point that her cataracts had developed to the point that she was being bothered by those. So brought her in for a pre-op, and she had shifted. You can see her refraction there. She was actually hyperopic in the right, even though when like a lens wear or something like that, that was actually her non-dominant eye. And she'd gotten to 20/60. And then the left eye was hitting about 20/30 best corrected, normal pressures. Right eye was 8 cut, left eye was actually 10 cut, about 2 NS. you know, she's really bothered. We then dilated her, and I noticed she had lattice 360 with an atrophic hole inferior on the right, and just a lot of lattice on the left. So she, you know, prior to her RK, she had been fairly nearsighted. Um, by the way, her pentacams and stuff looked surprisingly good. Her corneas were in. She did not have a lot of high order aberration on the pentacam, and they were fairly regular. It wasn't like we were dealing with an extremely distorted cornea, which I was grateful for. But I sent her out for retina treatment and cataract clearance before we did anything with those lenses. And a couple months later, she returned and she'd had barricade lasers in both eyes in areas that they thought were appropriate. And we were able to proceed with the cataract surgery in, it was like December of 23. Okay. We did do regular LALs, not a plus, because she was RK. She had some interesting stuff. And instead of doing some different slides, I'm going to throw this up here. So this isn't as clear as I thought it was going to be, so I do apologize. I thought this was clearer when I looked at it on my screen the other day or last night. But so she came in January, and her right eye refracted +1 -75. She was 20/30 distance, J8 at near, and left eye was 20/70 distance, and she was bothered by that because that was her more dominant eye. She had a little tiny bit of amblyopia in the right as well. 20/70 +2 -1, J6 near. So we did our first treatment targeting -1 in the right and plano in the left. Now you'll notice that the next treatment wasn't till May, because she comes back and we had a lot of fluctuating refractions. We had a lot of stuff going on, and I went into dry eye treatment mode. We actually put her on an immunomodulator. I believe it was Xiidra. We had her on tears. We did some things like that. And I was looking for stable refractions. Now, our pentacams weren't fluctuating much. We just weren't getting good results. And she kept saying things about filmy vision, filmy vision. This was an ongoing thing. It finally got, you know, I think I even did an amniotic treatment because it was so fluctuating. And you'll see that it was in May, I was able to treat the right eye again. But the first treatment did almost nothing. Her refraction was very close, but her visual acuity had improved from 20/30 initially to 20/25 uncorrected in distance on the right. On the with the refraction of +75 -1. So she's close to plano spherical equivalent, but she's not reading up close. She's still J5. And we played with the left eye a little bit more, but because she was 20/20, but complaining, we ended up with a stable refraction of -50. We targeted plano, and you'll notice that was like May, June. But I started refractor again, and I remember the day I pulled the phoropter out, and I'm going, wait a minute, because she was refracting worse vision than in the phoropter. And I pulled the phoropter away, and I said, can you read that now? And she goes, well, wait a minute, I have to wait for the film to move. And all of a sudden she did, and then she could read it. And I'm like, oh my gosh, look at this vitreous. And sure enough, we had sheets of vitreous floaters. She hadn't had that in the initial cataract evaluation, but since then she had been to retina. She'd had some barricade laser. There had been stuff going on in these eyes. So then I sent her to retina for a consult about the vitreous floaters. So she was gone for another couple months. She ended up with a vitrectomy, and in the right eye, right eye was the one that was really driving her crazy. And what was interesting, she came back and she goes, okay, the film is gone. Now I just need a little fine tuning. Came in, she was 20/40 in the rate, J1 plus, and left eye she was reading 20/25 with plano -75. we did one more adjustment. So our refraction was minus 150, minus 75 in the right, and plano minus 75 in the left. It took that left one to plus a quarter, and the dominant eye, and the non-dominant, I left the 150. I just kind of cleaned up the sill a little bit. She comes back and she goes, "This is life changing. I'm ready to lock in." I'm like, okay. So at that point, this is now, let's see, that was November 18th. She's back on December 2nd, and she's ready to lock in. But what was interesting was we still had some fluctuating refractions, but vision was more consistent. And if you notice, we had a -1 with 20/25 VA, J1 plus at near, and on the dominant 20/20 distance, plano -50, J5 near. But she's like, my film is gone, things are good. And so we were able to lock her in, and it stayed consistent on the second lock-in. And it was just interesting. I wish I had paid more attention to the film she talked about earlier on, because I feel like I could have saved her a lot of time if I had looked at that vitreous a little bit quicker, to get her to back to retina, to say, hey, can we do something with this? And my point is, the optics on these lenses, this is an RK patient. Her corneas were not very bad at all, but turns out that vitreous was interfering with our treatment. And when she came back to me, she's like, "Oh, it is so much better. Can we just fine tune a little bit?" And she goes, "This is life." I'll just never forget her saying, "This is life changing," because we did the combination of the vitreous and the last little fine tune. We probably could have gotten there much sooner had I been hearing what she was saying. This is me judging myself, but that's what.
It's a good reminder. It's a great case, Ken. It's a good reminder to actually listen to what they're saying. I do that all the time too, where you've got patients and you see these people enough that you kind of get to know them really, really well, and you kind of push away complaints that they're not really. A lot of it's just dry eye or just normal things, and other things that could be remedied. I do have a question for the group, and this is I've dealt with this. This has happened a couple times now. Twice where I've had patients develop retinal detachments, MAC on, thankfully, but detachments in the middle of their adjustments. So with those, we don't really have a choice. They have to go to retina. They ended up getting, I think both of them got vitrectomies. There's one patient that I've had like you, Ken, where the vitreous was just so condensed it was problematic. We could get stable refractions if I kind of like have her move her head around, and then we can get a stable refraction, and it was repeatable. So for her, I avoided sending her to retina until after. I'm curious what everybody's thought is about that. Proceeding to retina first before the adjustment, theory that if there's a change or a refractive shift, you could adjust back. Or do you worry about causing damage to the lens itself, try to lock it in, and then do vitrectomy after? Anybody have any thoughts?
I don't refer to retina pretty quickly, and I'll just say because my retinal specialists are pretty stingy on who they do surgery on, and so like I feel like I think that's probably what stops me the most, is just kind of thinking about the type of surgeons that I work with, and they don't do vitrectomies very often for vitreous floaters, unfortunately.
So I have the luxury of not having retina in my practice, and having a number of variable levels of enthusiasm in surgery from different offices. So I just pick the one that I want to do the procedure, and I send it over to them, and they generally have a very rapid threshold for doing PPVs. But yeah, I get your point. It's a mess if you're in a house and the surgeon won't do the case. Can't send them out, so you have to kind of lay back.
Yeah, and
I do have the luxury. I have a couple different retina groups that I work with,
Yeah.
and I have one group that's gotten very comfortable with LALs, because I happen to have had at least 2 RDs with LALs during the adjustment phase. And since this patient, I had one other patient that most of the time the patient's like, I don't want to lock in with all these floaters. I want to know that's better first. So this patient I took a guess at, but the second patient that I sent for a vitrectomy, she's like, I'm not locking in until I know that that we've got this taken care of. So I went ahead and sent her, and she got that. Everybody else, I try to say, look, we'll take care of those after. Let's just make sure we've got this going on. But there are times where it's just in the way, to the point that they're so distracted, I can't finish the case. And luckily, I've got this group that's pretty comfortable with doing it with an LAL in the eye that's not locked in.
And the other issue too, I think, Nick, is having a vitrectomy. 25 gauge can, although typically not significant, but I mean, there have been reports with induced myopia, you know, so if you lock them in and then they vitrectomy, you may alter your ultimate target for that individual.
Yeah, I mean,
Yeah, I think it's just best to let the retina people do their work and then hold it off until they're done and finish the case.
I agree with that too.
Finish the adjustments after.
Yeah.
Is that what you said? Okay.
Yeah,
that's kind of what I
absolutely.
thought. I mean, anecdotally, I would feel like the chance of a shift, it's small, but it's not minimal. Same with the YAG. I mean, there's a chance that the lens could move and then you're dealt with a shift. So doing YAG before the lock-in, I see both sides of that. And same with the retina, the procedures. Get them done
I mean,
first.
look, in the larger picture, this is such a much simpler path than a multifocal with notable floaters that's absolutely not functioning at all. And the discussion is explantation versus some other procedure. That gets a lot more complex, and nobody ends up being a happy patient or a happy doctor at the end of that. If you do enough cataract surgeries, we've done about 120,000, you get to see just about everything. And the LALs are just in the same plane, you just don't see as many. But eventually we're going to see all these complications, so it's nice to be able to chat about them a little bit. They will show up. I have an interesting quick question, hopefully interesting. So we do a ton of glaucoma surgery. Partner does about 100 to 120 glaucoma surgeries a month, not including cataracts. Some are conjoined, obviously. But I've noticed, in one patient particularly, I just couldn't, I mean, even though the heme cleared, she had a hydrus with an Omnidone in conjunction with with the LAL. And even though the heme cleared, I just couldn't get good contrast. And I've not really seen that in the past with monofocal lenses at a week or 10 days out when chamber looked good. Has anybody else experienced that? Or is it just maybe a unique patient? I don't know whether I felt maybe there was like blood in the capsule that I couldn't visualize. It's hard to say.
I have seen pigment deposit on the anterior surface of the lens before.
Yeah.
And
I can see that. Yeah. I didn't see it there, but I certainly understand it. Yeah.
Okay. It's not blood on the capsule?
You know what? I didn't see blood on the capsule, but she was acting as if there was a filter in front of her eye. She said, this one's dimmer than that one, even though the look was almost identical. So
did she have, like, what was the severity of her glaucoma? Because I've had patients who are like, oh, my vision's not great, but then I look at their visual field and they've got a central defect.
No, we don't operate on patients like that. Well, if we were going to do a lens, we'd probably just do a monofocal. But no, these are patients who they nasal steps and be a little germ. Plenty of central visual activity that's normal. And the numbers are good. They're up in the high 20s, low 30s. So they were fine. But this one is unique because she did have a fairly noticeable bleed. This was not just an average 2-day bleed. She was about a week out before I could even get a good look.
Jim, did she have any vit heme by any chance?
Well, you know what, Ron, that's something, I mean, I B-scanned her several times. On visual, that's what I said. I can't tell whether she has a couple of RBCs trapped in the capsule. They almost look like they're right behind the lens. And if that's the case, I'm not sure I'm ever going to get anything better. That's going to take forever to leave if it does at all. The vitreous, I think, will eventually settle, but not if it's behind the capsule. So, and I don't have my UBM anymore. It failed on us about 3 months ago, so I can't really give that.
I have heard cases of that where the blood gets caught in the capsule, and then I mean the answer is to YAG it then at that point.
Yeah, well, that's the next step, right? We just have to do a capsule YAG, right? So another quick question, and this came up in a conversation with 2 other surgeons who I'm intimately involved with, who I was in the room with actually, and said to a patient, don't worry about wearing the glasses inside. There's no need for that. Just wear them when you're outdoors.
That's what I
Correct.
that's what I
you
tell
do?
my patients. Yep.
Good. Okay. Good.
Sta-
Because that's not what the
Okay,
company's telling
FDA
everybody.
approval says,
Yes.
I understand, but the patients are coming in with all of this thing going, well, I have to wear these, like, do I have to wear them when I go to sleep? Do I have to wear them in bed? I said, yeah,
Yeah,
they
but
look sexy. I would wear them to bed, but otherwise, no. I just wanted to be sure we're all in agreement because that makes sense. I mean, there's not enough ultraviolet light to trigger anything inside a house.
well, the deal is that, you know, in 2017 or whenever the lens came out, it didn't have active shield. And
Right.
so they're not going to repeat the FDA trials, right? So active shield came out a couple of years ago, and since then, I think it's pretty standard that people are recommending no UV protection indoors. Don't, you know, remember Chayette did that study down in Mexico with like 200 eyes and
Right.
no UV protection outdoors.
Right.
And they did fine, you know, so post active shield, of course.
Well, it just makes it so much easier for the patient. Basically, this is just sunglasses. You know, you're just wearing some for sun protection.
Yeah,
exactly.
you get to be the hero too, because they always come to me. They're like, I read this pamphlet. I gotta wear these things all the time, and I get to tell them, no, actually, you don't. And they always say, are you sure? And I say, yes, I'm sure. But then you get to be the hero, which is always fun.
There you go.
Yeah, guys, we're coming up in an hour. Thanks for everybody's involvement.
Really good cases
always,
tonight.
yeah.
Thank you. That was very, very useful.
Yeah, can I ask
Yeah.
a quick question? So in
Sure.
this group, how many are doing these adjustments on referring patients more than even intern? Like how many of you guys are
good question. Good
co-managing?
question, Paul. Good question.
Because there's a lot of the discussion you're talking about now in the retina, and we're getting patients after they've had surgery and they're done. We're just doing their adjustments, and it's a little more difficult for us to assess the retina. We're not, you know, if someone has a new floater, they're not really our patient, you know, so we tend to refer them back, whether the referring surgeon wants to or not. But what in this group, how many people are doing mostly adjustments on external patients?
That's a good question for Jenny Wong.
yeah, she was here.
Well, look, we're Paul's part of the MOA group. We now have 11 locations. We'll have 15 by the end of February. They're all OD based open access centers for local surgeons. So everybody we get is a patient from somebody else's practice. We don't have a practice base to build these patients out of. So it's an interesting question, and Paul, we've all talked about it. It creates a different path to the end because we haven't worked with these people for 3 years, you know, before they decide to have cataract surgery. They haven't been referred in by our network doctors that referred to the surgeon's practice through a network referring co-managing doctor, but we don't necessarily know them. So I think Paul, I think you're pretty unique, to be honest. I don't think there's a lot out there. There are a couple other colleagues who are doing independent practice, but yeah, the model's different. So, but we're growing quickly.
Model. Yeah,
we're growing quickly. We'll have 15 lasers out 15 light systems out by the end of February. So,
well, it's a demand.
Boston,
I mean, there's
Boston through probably Northern Virginia. So.
Wow,
yeah.
That's great. It's clearly a demand, and I mean it's a unique niche that is definitely needed. And
Yes.
you know, there's several surgeons out there that want to do this lens because the technology is so amazing, but there is some work that comes with it, and there's an art to it, and everybody on this call understands the artwork.
The other part of it is surgeons typically are not going to refer to another surgical practice to get you to do their work.
Probably not.
That's not happening.
Probably not.
After 40 years in the business, I can pretty much say that unequivocally.
Yeah, no, they won't.
Yeah.
No, they won't. All right, guys. Well, hey, everybody have a great night.
Thanks,
Thank
everybody.
you so much. Plan on another one probably.
Is everybody going to SECO?
I will not be.
Okay. Just gonna say if
I'll
we're
be
there,
at
we should get together and have a cocktail and chat. So
yeah, we'll see you guys next time around.
all right.
Thank you.
Thanks.
Have a good day, guys.
Care.
Thanks,
Bye.
everyone.
Thanks.